Dr. Alrasadi, please go ahead.
Thank you very much for the generous introduction, and thank you very much for inviting me for this really prestigious conference. This is what we want to see as an equity in the screening, treatment, and management. So I will concentrate today on dyslipidemia and gender difference. This is my disclosure slide. So we have learned a long time ago from the meta-analysis of the different statin, and also now from non-statin treatment in patients with either primary prevention or even secondary prevention, that reduction of 1 millimole of LDL cholesterol will be equal to a reduction in almost 22% of cardiovascular event. So this is really across what we see in both men and women? Yes, and the evidence you have there in the slide from this meta-analysis. So you can see very clearly that whether we talk about primary prevention, patients with not known any history of cardiovascular event, both men and women, they have the same magnitude of cardiovascular reduction. Again, in patients with secondary prevention, so again, we see the both trends in men and women and in reduction, so, and the overall is there. So really there's no difference between the two gender in terms of responding to statin and reduction in cardiovascular event. Very, very important to put in mind. And again, this is what we see also in non-statin treatment as well. So going back to some of those studies or registries that has been done in the region here, and we are proud that some of the primary authors and investigators are here with us in this conference. So this is Gulf Race 1, 6 months prospective, multi-center, involving 6 Gulf states country, more than 8,000 patients, 64 hospital, diagnosis with acute coronary syndrome. That's again including unstable angina, STEMI and non-STEMI. And you can see that women were older than men by almost 10 years, and they carry more of these comorbidities. So previous angina were more statistically prevalent in women compared to men, 51% versus 37%. We didn't see that trend in MI, but cabbage, again, women have more cabbage than men, and that was statistically significant. How about the prevalence of risk factors? You can see very clearly that diabetes were more prevalent in women compared to men, 55% versus 36%. Hypertension is similar to that trend. So we can see very clearly, I mean, from this clinical characteristic of this patient, there are more comorbidities with the women. Does that reflect into also dyslipidemia as well? You can see it more clearly, more higher in women, 44% compared to 28% in women, and also other risk factors that I don't want to go through them, but they are evident. They are more higher in women than men. So how about treatment-wise? I mean, the beautiful things here in this table, that both men and women receive almost the same prescription of statin. So that's although there was, I mean, trends in less women than men, but that was not statistically significant. But again, and this is maybe one of the limitation of this Gulf Race 1 and Gulf Race 2, they didn't look at that time at the intensity of the statin. So this is the overall statin, whether patient takes statin or not taking the statin, but whether she or he was on high intensity versus low intensity was not captured by this data. And this is very, very important really to learn. And this is maybe was also captured by the other study that I will show it in the CFIUS study. This is again from the Gulf Race 2, showing the same, clinical characteristics. So female were comprised high in this group, and as again the baseline characteristic, female were older, higher BMI, more non-STEMI and unstable angina, more hypertension, more diabetes, more dyslipidemia, and so on. And at discharge, we thought maybe they will be treated better, but it was not. So we can see that men get more aspirin, Plavix, beta blocker, ACE inhibitor, and statins. So again, but this is, like I told you, we definitely need more studies to show what is the new trends in that. And so this is again from another study, the DIASIS study, which was done not only in the Gulf region, but also it extended to other MENA countries. You can see that Lebanon was there, Jordan was there, more than 2,000 patients were enrolled. And again, they were looking at the achievement of LDL cholesterol in this patient who was taking the statin, and you can see very clearly that although most of these patients was classified as very high risk, the achievement of LDL cholesterol was not high. It's almost 62% did not achieve the LDL cholesterol for this very high risk patient. And again, you can see that when we compare women and men in this group, again, women has more hypertension, higher BMI, more diabetes, and when it comes to the statin, again, they did not capture what this is again. High intensity or lower intensity statin treatment. But we can see that, the LDL cholesterol was not different in the two groups. Maybe the triglyceride was higher in women in this group. This is another study done during 2009, 2010. So it's, relatively an old study, included again more than 4,000 patients, and included again primary and secondary prevention in 6 Arabian Gulf countries, and again looking at the achievement of LDL cholesterol in this patient. So we can see that again the same trend that the BMI was higher in women. When we look at coronary heart disease, it was more in male than women, but diabetes was higher in female. And the beauty about this study, we looked at the intensity of the statins in this patient. Most of the patient, regardless, male or female or man or woman, they were on the low intensity statin. So maybe this is what is reflecting also from the other studies in the Gulf Race and Gulf Race 1 and 2, although it was not captured in that. So the trends maybe at that time, most of our patients as a clinical practice, we put them on low intensity rather than high intensity statins. And when we look at the achievement of LDL cholesterol and also non-HDL and ApoB as a secondary target in this patient. So this is, you are looking at two different types of patients. Patient with very high risk, so those patients with atherosclerotic cardiovascular disease and many risk factors, or patients with high risk, those without cardiovascular disease, but they have other risk factors. So if we compare men and women in the high-risk group, we don't see any difference in terms of achievement of LDL cholesterol, non-HDL cholesterol, and ApoB. In the very high risk, those patients with atherosclerotic, we see this difference. So we see that women were less likely to attain the LDL cholesterol than men, and also the non-HDL cholesterol. 34% versus 39%. But what we see also nicely in this study, in the same study, that when we stratified the patient, not only based on the LDL, but also based on the triglyceride. So those patients who also have a high triglyceride, and we have seen this trend. Women, usually they have a higher triglyceride, again, because of the obesity and prevalence of diabetes. So we looked at that. And to our surprise, this is where we see the big difference really between men and women in terms of LDL cholesterol achievement. So if you see at the very high risk women, only 10% had achieved the goal versus 21% in men had achieved the LDL cholesterol. And again, when it comes to the non-HDL and ApoB, which also reflect the importance of the triglyceride, we see less women achieving the goal. So it is really very important in women to concentrate only on looking at the triglyceride and looking at the non-HDL or ApoB, if you measure it directly in your lab, as a secondary target for these patients, which really make a difference when you want to intensify the statin, when you want to add ezetimibe on the top of statin for this patient. And then when we compare our results with the other international results from the CPS, almost the same trends, so we are not different from the others, from the other international. So we can see that in some of the study that women was achieving less LDL cholesterol compared to men. This is again from a recent study from the Poland group. It's called Polyspire. It was part of the Eurospire 5 study. So again, they were looking at the clinical characteristic of men and women in patients, again, with acute heart diseases. So we see almost the same trend. Hypertension, diabetes was almost more common in women than men. Dyslipidemia, almost the same thing, but obesity, again, higher in women than men. And then when they looked at the achievement of the LDL, according to the 2009 European guidelines, you can see very clearly, even they have the same problem. So only 7% of women achieving the LDL cholesterol in this very, very high-risk group versus 8% in men. So, but the non-HDL, you can see the big difference. Again, this is why it's really very important to also capture this non-HDL, especially when the triglyceride is high in this patient. And they looked at the intensity of the statin. So again, in their study, maybe it was more evident than in the CFS and in the Gulf race. So women were receiving less statin prescription than men in their study. And also, they were not only that, but high intensity also prescribed in women less than men in this cohort. So what we had learned so far, that really concentrating on women with different risk factors is very important. And now we can see in the different guidelines, whether we talk about European, American, or even the Canadian. So what they do, they start adding this, what we call risk modifier. So if you have a patients who have, low or moderate risk, and then you want to upgrade him to a high risk, then you look at this risk modifier. It could be molecular, genetic, it could be biomarkers, it could be imaging, like the CT calcium score or CT cardiac, for example. So if it is proven positive, then you can upgrade this patient, and then you can intensify the statin. Or even a patient who are already with attack cardiovascular event, and you want to put him on this non-statin, relatively expensive treatment, then this modifier risk is very important. So we can see it's not only biomarker, not imaging. So we can see even sex-specific condition like pregnancy-related hypertension, preeclampsia, and so on was added to this, as a risk modifier. So if they present, then they can upgrade these patients to a higher group, and it can, this patient can be on high intensity. I think my colleague have, highlighted this before. So according to the European guidelines, what's the management of dyslipidemia? Statin is recommended, whether we talk about primary prevention or secondary prevention, very, very important. And they should be, again, according to the same targets that, for the overall group. So if they are very high risk, then you should reduce it below 1.8, and if recurrent event, even less than that. And for a high risk, it should be around 2.6. How about pregnancy? We know that, unfortunately, we don't have any agents that is relatively safe in pregnancy except LDL apheresis. So, and usually because this is an invasive treatment, we use it only for those patients with at very high atherosclerotic cardiovascular disease, or if they are proven that they have a familial hypercholesteremia or a high lipoprotein little a, and you are afraid that, delaying the treatment during pregnancy and breastfeeding will, increase this atherosclerotic cardiovascular disease in this patient. And if you have it available in your center, then it will be really a good option. But statin, ezetimibe, and PCSK9 still not proven safe to be used in this patient. And again, talking about the, how the LDL cholesterol should be, it should be similar in both gender. So I will stop here. In conclusion, dyslipidemia is strongly associated with cardiovascular disease in the Gulf region and also in the MENA region for both men and women. Due to a high cardiovascular disease risk profile in women in the region, there's a high need to adhere to guidelines in terms of aggressive lipid-lowering treatments and develop maybe public awareness programs that, again, the first presenter from Jeddah, she had presented the importance of this public awareness program, whether media or other channels is very important. Thank you very much.